But that's not true really for the majority of Africa. What do we do in pediatric critical care? If we say, what exactly is pediatric critical care? I think all of us do pediatric critical care because we all see children that with life-threatening illnesses. We all see children with life-threatening injuries. We might not be treating them in fancy buildings, but we're all doing pediatric critical care. A number of these kids need intense support post-operatively after major surgery. But I think one needs to change mindsets. That pediatric critical care is really a continuum from the first clinic visit, from the first meeting with the healthcare system, the recognition of that illness, the oxygen that the child gets, the fluids that they get, the antibiotics, that's critical care. The thing about what makes critical care really different is everything we do is time sensitive. If you have a child who's shocked, there might be fluid and inotropes, not tomorrow, not in an hour's time, they need it immediately. And they need the antibiotics. They need oxygen with hypoxia. If you don't intervene in that early period, the outcomes are significantly worse. I mean, this picture is really, it's really a depiction of what the reality is for most children and families, I think, in Africa, with poor access to healthcare. You've got families that often seek traditional medications, not really seeking medication or healthcare early. There's often a delay in traveling, not sure what the transport system is like in most countries. There's often a delay in receiving help at those facilities. The care might not be completely appropriate. And all of these delays and low quality care impacts the outcome of those children. How big is the problem? How many kids do we have in Africa? If you're looking at population pyramids, in Africa we've probably got 1.3 billion people. Roughly, if you look at it, probably about 40% of children are under 15 years of age are children. So when we're thinking about health budgets and facilities, are we attributing large portions of our budget looking after children? Probably not. Looking at global, regional, and national trends in under-5 mortality, this is a recent publication of the last 20 years, looking to see, what's happening to kids. If we're looking at neonatal outcomes, and where does your eye fall? Your eye falls on Africa. And if you look at the graphs, if you look at the legend, in terms of neonates are dying mostly in Africa, Asia, Southeast Asia. And if we're looking at children under 5, similarly, Africa, an inordinate amount of burden of children deaths. But if you delve deeper, if you have to probably look at a country level, there are areas of high care within each country where those mortality rates are actually very low. Similarly, if you're looking at Africa as a whole, there are countries that are doing really well. Within each country, there are areas or regions where mortality is low, but they are not receiving the same care all over. Why are children dying? And it's the same suspects. If we're looking over the last 20 years, unfortunately, nothing really has changed. 20% of children die of pneumonias. Diarrhea still kills many children. And post-COVID, with immunization programs probably not working as effectively as they should, many children are presenting with potentially preventable diseases. I believe there's a measles outbreak in many countries. In South Africa, we're seeing a pertussis resurgence. Tuberculosis is rampant again. So children are still dying from the same causes. Who knows the song, "Money can't buy you love"? No? But it can buy you health care. And fundamentally, if you look at where children are dying, those are the countries that spend the least amount of money. So if we're thinking about budgets and healthcare expenditure, if we want to be improving outcomes, we need to wisely think about where we're going to spend our money, what systems are we getting in place to ensure that we actually achieve goals. It's one thing throwing money at a problem, but you need good governance and supply chain and systems to make sure that quality of care is delivered. But it's not all doom and gloom, and I think over the last 20 years with multiple programs and all the big players were here earlier, WHO, UNICEF, but there has been a reduction in morbidities and mortalities in children. Probably not as much as we want, but the trend is definitely in the direction. And if we're asking why are fewer children dying? It's probably not intensive care, if one's truly honest. It's the simple stuff. It's immunizations, it's access to health care, vaccinations, water, sanitation, housing. But there comes a point where you reach a ceiling and you need to be pushing boundaries. What can money buy you? Money can buy you a functioning healthcare system. I think bricks and mortar is probably the easiest thing to do, to build something. But to staff it is a completely different story, and we'll talk a little bit about staffing a little bit later. But I mentioned earlier about continuums of care. When you have children presenting with acute illnesses to communities, that's where the critical care starts, and it starts really throughout the referral pathway, up through secondary hospitals, rural regional hospitals, to your referral centers. And similarly, once they've recovered, they need to be referred back down that pathway. In terms of, I spoke a little bit earlier about supply chains, you can't do critical care, you can't do emergency medicines without equipment. Oxygen is a huge issue in Africa. So just making sure that you have the correct medications, supplies, fluids to actually intervene. In terms of equipment, and yes, equipment's expensive. Many times, many places unfortunately have equipment. They have equipment, but when you speak to them, nobody knows how to use them. They've been donated. It's covered in dust, and unfortunately, it's a major problem in intensive care units. I think if we're looking at cost is a significant barrier, but point of care machinery and equipment is probably the way to go. Laboratory tests aren't easy to come by. In terms of equipment, many people think critical care or intensive care, intubation, ventilation, that's going to save kids. But if there's been a delay in the pathway, often kids come to hospitals too late. And I think a lot of our focus should be on non-invasive ventilatory support. If we can recognize kids with serious illness, and the majority of children have respiratory causes, if you can recognize respiratory illness, intervene early, and when I say intervene, maybe some high flow, some CPAP, providing some non-invasive support, you often prevent kids from deteriorating if you've given them their antibiotics, they've had some oxygen, and you're buying them time. But if we can use non-invasive type ventilation, we would need to ventilate fewer children and there'll be less of a burden. Just in terms of intensive care units, once again, I think critically ill kids, there aren't very many intensive care units in Africa, and if you look at the data, it's patchy, It's very difficult. I've been trying to find out in Africa where the intensive units are, but some of that data, there is some data, but not really very clear data. But many kids end up being looked after in adult ICUs, as you know, pediatric wards by general pediatricians and by anesthetists. What do you do when you don't have resources? And sometimes we make those hard decisions, and what you see is that people understand there's a limit that what we can do. But I think if you're in a resource-constrained environment, it's important that we have those difficult conversations that this is how much treatment we can give with our current resources. And that's the sort of admission-type policies to intensive care. Unfortunately, one can't admit everybody to an intensive care unit, but you have to have admission criteria. Sometimes if kids are presenting too late, no matter what you do, the outcomes are going to be poor. Specialized care is also quite tricky, and I've seen many, if you use pediatric cardiac surgery as an example, there are multiple highly specialized teams that visit quite regularly all over Africa, providing cardiac surgery to kids. And it's great that they come, but they're probably just seeing a small fraction of children that need cardiac surgery. Many of these teams transfer skills, upskill local clinicians, and that's what we need to do. We need to improve our own skills. I'm sure many of you were involved in the study. Want to put up your hands if you were involved? Come on. Come on, don't be shy. Okay? Speaking to, we're all busy clinicians. People are saying, I'm too busy, I can't do research. I love seeing patients. But we all need to do research. When you speak to Kat Maitland about fluid and the study, she was saying that all the clinicians involved in the study thought that the kids who had fluid boluses who were shocked did better. So when they analyzed the data, everybody was really, really surprised that the kids who had fluid boluses had increased mortality. But this is an example of a study that has really changed the way everybody in critical care looks at fluid administration. It's kind of a knee-jerk reaction. A child presents shocked. What does everybody want to do? 10, 20 mL per kg of fluid. But not every child needs fluid. And I think when children present with shock, try and find out the cause. What this study has done is it's really changed our minds and made us think more critically. If I give a child too much fluid, I might push them into pulmonary edema. But if I don't have an ICU, have I harmed them? And it's not just in Africa where it's changed people's ways. I mean, if you look at the American guidelines, the surviving sepsis guidelines, they often pour in 60 mL per kg of fluid within the first 20, 30 minutes of a resuscitation. But they've got intensive care backups and they've got resources to cope with that if the children go into pulmonary edema. But studies in Africa about African children affecting the way we manage kids is what we need. Kat Maitland did a similar study, in Malawi, where they changed the organizational skills of their hospital. So changing with triage, with training existing staff, flows of patients, they managed to reduce mortality by almost half. And this is what we need to do. We need to look at what we do and see how we can improve systems and make children for the benefit of children. There's another saying that you all know, it takes a village to raise a child, but similarly, it takes a large amount of people to care for a critically ill child. If you have patients in the center, it's not just the doctor, there's a whole team of people that needs to be involved. Nurses, physiotherapists, nutritionists, respiratory therapists if you have them. But do we have them? Very, very few, unfortunately. A recent study again by Ahmed looking at a health workforce status in Africa. This is pre-COVID. I think it's a lot worse now, 3 years later. But what they did was they didn't just look at doctors, they looked at all categories of healthcare workers, admin staff, support staff. The WHO has a threshold of 4.45 healthcare workers per 1,000 population. And unfortunately, only 4 countries achieve that. South Africa, Namibia, and I think it was Mauritius, there was another country. But we don't have enough healthcare personnel in Africa. In terms of pediatricians, if you just had to focus clearly on pediatricians, where are the pediatricians? Egypt is doing something right because they've got a huge amount of pediatricians. Red is if you have more than 100 pediatricians per 100,000 of children, but very few pediatricians in Africa. So maybe just to change tack slightly and talk a little bit about the African Pediatric Fellowship Program. I'm a supervisor on that program. And what the African Pediatric Fellowship Program has done as its aim is to try and strengthen African workforce by training people within Africa. We're based at the University of Cape Town, the Red Cross Children's Hospital, which is a large sort of multidisciplinary tertiary quaternary center. And the realization is that people who train, subspecialist training, often go abroad, and many of them unfortunately don't come back. And what we're wanting to do is train people in an African context where we understand local priorities, infrastructure, and hopefully keep them in Africa. It's also to not just increase the individual, but to partner with institutions that will hopefully, that have chosen individuals to increase capacity within regions, to not just train them, but to support them to develop curricula to become a nucleus for training programs in the future. I'm going to say that. But it's not just about individuals, it's about training teams. So from our one hospital, we've extended it to 2 other hospitals within South Africa, University of Witwatersrand in Johannesburg and Durban. And we're extending it now to training nursing teams that are going to work with doctors, physiotherapists, and technologists. So training teams of people to make impacts in whole healthcare systems. Over the last, since 2007, more than 200 African pediatric professionals have been trained across multiple specialities, and you can see the uptake. And where are these people? And I think more than 90% are still around. So 15 years later, many of these healthcare professionals are working in Africa. And that's really unprecedented. In terms of pediatric intensive care, we have a large 22-bedded ICU, do a lot of cardiac surgery, trauma, but we offer a 2-year fellowship program in pediatric or critical care and a one-year diploma. In terms of training thus far, what we've done is we've had fellows. If you look at the greenest sort of, the blues are where we've trained individuals from, and it's an expanding number, but slowly we're making some headway. In terms of neonatology, there seems to be an East African flavor. Lots of neonatologists are being trained, and even in Tanzania, we've trained. There are 3 neonatologists that have been identified to really train the next generation, to develop curricula, to establish a highly functional neonatal service, and make changes within the whole country. Joe Wilmses is the director of the program, and together with Helen Menkes, they do an amazing sort of work in terms of fundraising. I would encourage you to go and read that article that they've published. But getting back to critical care once again, and how can we advance, how can we improve things? Andrew Argent, who was my boss and my mentor, sort of published this paper a few months ago. And I'm not sure if you heard about the 80-20 rule, you know? So suggesting that you identify top conditions that pose acute life threatenings in your region. We all have different challenges. And then most of them are infectious diseases, but target what's relevant to you. Similarly, there's a small amount of patients, if you look at the 20% of patients that consume large amounts of resources. So somewhere one needs to make sure that the resources are directed towards the majority of the patients, and it's not all being consumed by a very small group of patients. And sometimes it's a luxury to have an intensivist and emergency medicine person. Sometimes you need to have a person that does both roles, an emergency physician that works within critical care, and similarly in different circumstances. But think about what skills these people need to have. So if you're thinking of resuscitation skills, IV access, being able to look after really critically ill kids, try and think about what skills are mostly important and focus on those. When we're talking about equipment, don't focus on the very expensive equipment, but think about low-tech equipment. And I've seen the Pumani CPAP machines outside, equipment that doesn't need, that won't break down, that'll be quite tough. But also think about who can support them. If they do break down, you need support and you need supplies in order to keep them going. And focusing on prevention, we're talking critical care, but if you can prevent kids from becoming unwell with vaccination programs, clean water, then you reducing the burden of critically ill kids on intensive care units. So really maybe just to leave you with some parting thoughts about critical care is that that we need stable political systems with investment in order to improve outcomes in kids, with healthcare infrastructure, equipment. Training and retaining staff has to be a priority for us. We need to constantly advocate for appropriate resources. And if we really want to improve child health and survival, we need to be able to recognize critically ill kids early. We need to intervene immediately if we're picking things up as life-threatening. And critical care is about attention to detail, doing things, making sure that you're checking the glucose and doing everything that is necessary. And I leave you with a comment from Nelson Mandela, who says, there can be no keener revelation of a society's soul than the way in which it treats its children. Thank you.
Thank you so much, Dr. Shamil, for a very insightful talk. You really managed to define what it is as a definition of pediatric critical care in the context of Africa. And it should not really necessarily mean having expensive equipment and stuff. Otherwise, it's rather a continuous from the first time when the patient meet the doctor to the time when they exit the hospital facility. But it is also time sensitive and the need for things such as oxygen and antibiotics. And you went on and focused on the issues of the poor access in the region about it's one of the major challenges affecting critical care in Africa. And you talk about budgetary issues and allocation towards pediatrics in the continent where about 40% of individuals are children under 15 years. You also alluded on the causes of under 5 mortality. That hasn't changed much over time, but of course you made the point that we have seen some change and we have had some improvement heading to the right direction, though not necessarily at the speed that we would love. But nevertheless, you talk about the intervention that we should focus on non-invasive ones and less expensive one with low-tech equipment. The issue of research that really much inform and change the practice, such as the FEAST study that has changed what we do in terms of practice, especially on fluid therapy globally, but mostly in African continent. And you also talk a bit about African Pediatric Fellowship Program, of which I'm one of the beneficiaries in Tanzania, and some few colleagues of mine here. And we've seen the support after training that we have got, including him being here, is one of the support that we have as from APFP. So this is really commended, and I hope many other pediatricians from Tanzania will think of trying to join the program and many other programs that we can start locally after the training, so that we can have sustainable training of a human resource that we are short of in our country and continent as well. And you talk about how we can advance care in Africa, issues of management of equipment, issues of preventive measures rather than trying to focus on treatment, as well as training and retaining of experts that are being trained is one of the important areas, as well as advocacy for the appropriate resources and allocation in our setting, as well as importance of child health and survival. But one thing that I take out of this is money can buy you health care. This is really important message that we need. Only thing is we really need to make sure that we do the appropriate management so that this money that we have, no matter how little it is, can actually change what we have. So ladies and gentlemen, I welcome some few questions out of this session. Please feel free to ask. Thank you very much. Any questions? Don't be shy. I know you just had breakfast, you have energy. Please, let's use it. You have no question whatsoever? Really? Is there any hand that I can see? Somebody help me to shout. Yes, please. Thank you, Dr. Msaki. It is directed to you.
I'm sorry, I thought you had it. This fellowship program seems to be such a nice thing. Can we know more about it? And how do we join that program?
So the APFP has partnered with certain universities. So they partnered with Muhimbili, and the emphasis is that Muhimbili chooses individuals that they want to set on a career path. So I think, first of all, I think if you're in Tanzania, you need to be part of a training institution. And I think the institution knows the individuals that are committed to improving child health. So definitely you need to approach your local bodies. APFP communicates with various organizations across Africa, and then between them they decide on which candidate would be appropriate and where the needs are. I mean, APFP doesn't know what Tanzania needs, so we very much take our guidance from the local universities in terms of what skills need to be upgraded. Yeah. 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 Yeah.
Or maybe this is because they are busy with their skills. I can't somehow they'll come with me in the village there.
Yeah.
That's
Yeah.
it's
Yeah.
a very good program, but can we confirm and really
Yeah. Thank you.
Maybe to add on that, APFP, although it works with some of the university, but it is not limited to work with universities only. There are a couple of people that have applied and managed to go for training without using academic institutions such as Muhimbili Muhimbili University. So it accepts all applications, and then based on merits, they get to know who they can accommodate in the program. So it's not, so Muhimbili University had made some effort to make sure that, because it's a training institution, it needs most of the lecturers and individuals who are working there to start local training in Tanzania. That's why they've managed to make sure that they create that association or bond so that they can train their people, so that we can train locally all Tanzanians who can benefit from this program. But anybody who wants to be trained, they can definitely apply through their website of APFP, and then based on their merits and the needs, of course, they do a vigorous way of screening people, and you have an interview to make sure that you are accommodated in the program. So I encourage those who feel like they need and they are passionate about what they want to specialize on to apply, and definitely they will be considered for that. Yeah. Karim, welcome. Can you have Mike over there?
Yeah. I can hear you.
Thank you very much. And really appreciate the data that our colleagues share with us from across the region. And just wanted to hear maybe your comment or your sort of factor. The issue of brain drain, I think this has been there for some time now. And in a number of fora have been discussed, just want to be your comment on experience. Because when you brain, that means you are shifting from one part to the other. And in terms of putting in place a solution that is likely to be practical, sustainable, all ends turns out to be in the process. So I just want to hear from you. How do you see us as a region? Because like acting as a single country, as a country, is not sustainable. So that kind of coordinated regional sorts of action, regional strategies. This one is for your comment.
Yeah. You know, that's a very difficult question to answer. But I think it's innate in all of us that we keep wanting to improve and we're wanting better things in life. But part of that is of trying to improve ourselves when we're seeking knowledge, then we often move, the further we move away from our base, the more difficult it is sometimes to return to where we started. I mean, one of my colleagues, and I give an example of, there was a Ugandan gentleman who trained with us with PICU, went back to Uganda, couldn't find a work as a pediatric intensivist in Uganda, ended up going to sick kids in Toronto to train in cardiology, couldn't find a job in Uganda, and is now in Australia. So sometimes we become so super specialized that there's no jobs or places for us to return to, which is a problem. And we all, you know, if we're looking at our lives, we want to enjoy what we do. And so the question, how do you solve brain drain? It's really, I don't think there are any easy answers to it. What the APFP has done is try to partner with institutions, trying to find individuals that are committed to staying in Africa. You know, everybody will promise and say, yes, I'm going to stay, but trying to identify individuals within organizations that are committed, that want to make an improvement in Africa.
Maybe I can also put some light on that. In this very room, there are a couple of people that have been trained in South Africa, in Israel, and many other countries who have come back and they're working in the country at the level of subspecialty, and we appreciate their commitment to the service. And I believe as a country, we cannot stop training people inside the country and outside the country fearing the brain drain, because it will happen whether we like it or not. But still there are people who are going to be retained, and we've seen the fruit of people who are being retained. So I think the spirit of getting more knowledge and skills should continue no matter what will happen after that. So I think if there are challenges of infrastructures and facilities, that we should look into a different eye and see how we can improve our infrastructure so that these people who are going for training, they can come and work in those environments and improve the outcome of our children. So I think that should be one of the top. When we are trying to talk about brain drain, we should also think of the infrastructure and facilities that we can do, as well as at the moment in our country, we are training more doctors than the system can absorb. So eventually they will go and work outside. We can't stop that. But we can also not tell the government not to train these people, because we, Namala, and other people are getting old and will be out of the system. There should be other people to take over when we are done. So I think we should continue to train no matter what.
Thank you. And then we can continue to the rest of the discussion. Sorry, because we don't have much time. Yeah, thank you. My name is Dr. Supa Tunje. I come from Kenya, and I am a neurology fellow. I'm training within our country. So one was to just make a comment and say that the APFP program has really benefited our country because we have quite a number of pediatricians who are from the program, and currently we have a number of fellowship programs in our country, and that model that is being used is to select pediatricians who are working in the county governments around the country, and that helps in terms of expanding the expertise within the nation. And so perhaps for Tanzania, you can consider that as a good model, just to make sure that we increase the knowledge around the country.
I was going to echo what you just said. When the APFA program has started, we have people not only from the universities but also from the hospitals. And we have had the campus here in Namalama. He's working in the pediatric intensive care unit. And he's probably the main person for this transition and learning. And if you come and visit our PICU, you will not find anything different from where you are in Europe or where. Which is a state of art. And we started our master's of science in neonatology, the postgraduate after a program. And they were expressing our heads that they were practically only two neonatologists. But then we had neonatologists from one, not from one. We joined in the bandwagon trained MSc neonatology. And we have Martha here, who is not from Mohas, the honorary but it's from really hospital. And after the demise of our mentor and our friend teacher, late Dr. Masao, we were thinking now, Karim cannot do this alone. I was only the one of the many getting us neonatology in the background.
Yeah.
But lo and behold, we came back from South Africa to the APFA program in Fiji in my lifetime. And I cannot do any neonatal things without our training. So it needs to start somewhere. And we cannot just go and start announcing, I want any song you can hear from any village or any place coming to it. How do we take it? You don't have somebody to hold on to them. The university or hospital or Ministry of Health. So I think you are doing a great job now. More people know about it. So this is going to the We have pediatric urologists who also came in South Africa. We have Professor Korea, the only practicing pediatric nephrologist. The other pediatric nephrologists who don't practice pediatric nephrology. A state of art is not necessary. You have to, an opportunity is not necessary. You have to create the opportunity. Now, all the people who do a nephrology training cannot get the door pass to this. And therefore, she has to cut me, but I think we are very passionate about being trained in South Africa.
And maybe just to say that, Martha, I think you're going to be the trainer for the next generation of neonatologists. So APFP is about training a core group of individuals that can actually take the country forward. So to create, you need to build capacity in whatever training programs you have. It can't just be reliant on single people, but a core group of individuals that will develop curricula, develop training programs, research programs that will train the rest of the country and the young people coming through the system. Thank you.
Yes, absolutely. I think it is nice that we have the program affording us the opportunity to go to train in South Africa. I've had the opportunity to train in South Africa, in India, and in Norway. And I can assure you guys, there's nothing usual as training in your own city. Because in my training in India, I had a big tag which is saying an observer. That means I'm not allowed to proceed in that kind of situation. Because I'm not licensed. I was licensed for sales. And the South African system provides us with practicing license. So you are allowed to practice there. But in the system, you have to move with the family, you need to have transport, you need to be able to live in that sense. So the only thing that I would say is, I think it is very, very brave for all the trainees that have been able to train outside to come back home and say that this training is expensive. if you get an opportunity to train friends and such, the best kind of things. You know, just one of the reasons is not that they are not being recognized, it's because that they have been trained in such a sophisticated system that they have been, you know, their mindset, you know, is programmed in that setting. If you train in UK, if you train in Canada, if you train in Australia, you will never think that there will be a shortage of cannulas. Because these things are always provided there. Nobody is thinking where these patients will be sleeping and what happened, you know. But when you come back here, you have to think. You are asking somebody to go out and buy a cannula that you have to use, and if you drop it down, you're in trouble. You need to buy another one.
Thank you, Prof.
So that's the kind of setting that we have. So sometimes training in your own setting makes life easy. And I guess it is also difficult for these people when they come back because you have to work with people, start slowly, and you get there. You should not aspire to have the ICU that Dr. Shamil is working with, but you'll get there in the next 20 years.
Maybe shorter. Asante sana, Prof. Thank you. So I know it is stimulating questions, discussions, but we always have time. Like towards the end during the lunch break, you can meet with Prof. Shamil, Namala, Furia, and everybody else and discuss it further. So we're going to the next session of this afternoon session. And our next plenary is on pediatric HIV, situation and field experience on community-based model on addressing treatment gaps in Tanzania. And the chair for the session is Dr. Topista Masenge and Dr. Jacqueline Urio. May I call to the podium the chairperson so that she can invite the panelists. Karibu.
Asante, good afternoon to everyone. I'm happy to stand before you to chair this session, and I'm going to call upon the panelists. So I would like to call upon John George to come in front with NACOFA representative, as well as Dr. Lilian Komba and George Loy. Please come forward. So this is a 90-minute session, and but in between we are going to have 4 presenters, and at the end we are going to have 20 minutes question and answer. So please jot down your questions, comments. And our first speaker is John George. John George is a visionary leader, a public health specialist, and a nurse, and an investor serving in public health programming for over 17 years. He is passionate to adolescents, youth, HIV/AIDS, reproductive health, maternal and child health programming in Tanzania. He is a certified program management for development professionals. He is currently serving as the acting chief of children and AIDS with UNICEF Tanzania, and previously has led 4 reproductive health projects, including adolescent and reproductive health at JPIGO as the program director, and before that, he provided technical leadership and program management oversight to 7 reproductive maternal, newborn, and child health projects at Amref Health Africa as a program manager. He also has provided technical leadership on HIV prevention program by fostering gender transformative behaviors as the technical advisor within Gender Health Tanzania and FHI 360. So John, please, you're welcome to start your talk, and thereafter you'll introduce the representative from NACOFA to do her talk. Thank you.
Thank you very much, Chairperson Dr. Teopista. Good morning, everyone. So straightforward, I'll be sharing with you some highlights about the situation of pediatric HIV in Tanzania. And specifically, I'll take you through the global happenings and what's happening in Africa, zero in Tanzania, and also discuss about challenges and some suggestions for these challenges that we have. So I think you have seen from the previous presentation that HIV is one of the leading cause of death for our children in the continent. And despite that, today we are discussing about non-communicable diseases. But I understand from previous presenters, they also mentioned about the chronic illnesses that can also result from HIV. So some of these children will also result into some of the illnesses that they will get will also be related to the HIV as well. So looking at the globe, we for the pediatrics from last year estimate by UNAIDS, we have seen that we have continued seeing the new HIV infection for children. And you see we have about 160,000 children who were newly infected. And also we had 98,000 deaths. We have 1.7 million children who are living with HIV globally, and this is the same population of total population of Tanzanians who are living with HIV in the country. So if you can remember that. About 50% of those are children, so that's not good news. And you can also see that majority of children who are living with HIV have not been able to achieve viral suppression comparing to adults. That's not a good news for pediatricians and of course for the country, especially East and Southern African countries. Looking at the population of children who were newly infected in 2021, half of them are coming from 6 countries, and Tanzania is one of those countries. And you can see that it's kind of a priority disease in the country, and of course we need some intervention for this, especially for children. Looking at the vertical transmission in Africa, we have about, starting with the global data, we have about 75,000 new child infections that are occurring that are also not diagnosed. And we understand that we have a challenge, especially in Africa, especially Eastern and Southern African countries, where we are contributing to a very big number of mothers who are living with HIV and who have not been diagnosed as well. So that's also is an alarming situation because they will contribute to the new infection for the children who will be born. And some of the data shows that the mother are infected during pregnancy and during breastfeeding. So mothers should be tested twice, when they come for ANC and when they are already continue with the breastfeeding after delivery. Coming to Tanzania, I said earlier that we have about 1.7 million people living with HIV, and the majority being women. And looking at that, we are seeing that there is kind of progression in terms of decline in terms of the speed, but still we are seeing new infection increasing. You can see from 2010, past 11 years, we had 1.3 people, and now we have 1.7. Again, looking at that, you can see that children are contributing to about 17% of the new infections in this country. But looking at the children from 0 and of course adolescents and up to 24 years, they are about 50%, almost 50% of the new infections. So that's also not good news for most of you who are here, saving most of these kids and the adolescents. Looking at the vertical transmission, we have not seen progression on this area, especially the vertical transmission, which stands at 11%. And of course, globally, we're expecting that at least if we had 5%. So in Tanzania, we have 11%, and the early infant diagnosis is very low at 55%. But again, when we talk about early infant diagnosis, still we see that 60% of children who are living with HIV are from 5 to 14-year-old. So the story about early infant diagnosis should be not a priority. Of course, it should be a priority, but still we also need to think how we can reach the 5 to 14-year-old who are not normally coming to the clinic regularly for child care again after 5 years. So this graph is saying what is demonstrating what I've already said, but one thing, if you can look at the orange graph, is showing that in 2021, the PMTCT coverage in this country went down. We were kind of celebrating by 2020 that we were about to reach 90, but then after 2021, we are seeing it had gone down, and to some extent, this it seemed to be contributed by COVID and the concentration that we had on COVID. And of course, I think some of you know that we have seen some decline on vaccination coverage, of course, in most of the Southern African countries when COVID came. So this is one of the phenomena that we are also seeing here. But our target, of course, should be 95, or even 98, actually, because of the coverage that we have in terms of the service provided. But I think the mobilization is still a challenge. This map is showing the comparison between 2016 and what happened in 2020. As you can see, the coverage in 2020 was not really good for PMTCT, and most of the region, I would say, had no good coverage, and it was standing at 56%. Sorry, I think it was standing at 42%. But then now, you can see still you have seen from previous graph, it is only 80%. But then an alarming situation here is for Dar es Salaam and some region like Geita and Kilimanjaro, where the coverage is very low. Maybe you might know the reason, but maybe this is something that we can discuss also. Our progress toward 395. We have targets of diagnosing all people living with HIV. 95% of them should be known, their status should be known, but also 95% of those who are known their status should be on treatment and also viral suppression. But then still, you can see we are progressing well, generally, when you look at the general population on the current status. But when you go to children, you can see the viral suppression, for example. Maybe I can pick the identification is 88% for adults and 97% for adults. But then when you come to what's happening with the children, you see the coverage. So the coverage actually for ART is very low. I said that we have about 90-something percent of children who are living with HIV, and only 58,000 are on treatment. And this stands for 60% of those, all children, and it's something that we also need to work together to find them. This graph is showing the numbers, and actually this means a lot. Number of children who are living with HIV in this country, and of course it's the progression graph showing from 2015. The number is going down, which is good news. But looking at the number of children who are enrolled on treatment, the number is actually stagnating. That's another thing that is demonstrated on this graph, which is important information for us to think about and to work together. And actually, some of the work that we'll be discussing here today, it is going beyond the clinics, going beyond clinics and to the communities and finding some solutions in terms of how can we get some of these children who are not on treatment. But then again, another thing that you have also seen or heard from previous slides, even the viral suppression is also not good for those who are already on treatment. This graph here is showing the mothers and the children. So the red one, I think that's red, isn't it? And then the other one is blue. Normally they say we are blind. So the red is women, mothers, and the blue is who? Who are those? Children. So the graph speaks by itself. So you can see this is the coverage for PMTCT. So the question now is, where are we losing these children to match with their mothers, if it happens that they are already also positive? So it's not really good news in terms of pairing mothers and their children who are infected or living with HIV. This one is talking about death, and actually maybe I may highlight quickly that we had last year 6,000 deaths, which account 21% of all AIDS-related deaths in this country. And of course, for young people of 15 to 19, 15 to 24, we had about 2,600. So, of course, majority being female, and I think you also understand the dynamic of HIV infection in the country, that for the new infections in the country, normally we are consistently seeing more adolescent girls and young women being infected comparing to the counterpart of the same age. So we have some suggestion, of course, against the challenges. Some of the programs that are implemented in this, I think I'll say most of the programs that are implemented in the country are supported by development partners. And it's actually the Overseas Development Assistance. And we are working together with the government to see how we can cover the gap in terms of the funding. Actually, I think it's more than 90%. Is it 94 or 2% of the funding for HIV is coming from abroad? And some of these programs, they have their targets, which is really good. But again, of course, these targets are also matched against with the country priorities. But again, the other thing that is happening here is that we are missing children from low volume sites, because partners who are supporting some of these programs, they're interested to see that we are targeting high volume sites. But then cumulatively, if you see what we are missing from low volume sites in terms of delivery and whatnot, ANC and so forth, eventually we are missing many children. And of course, one of the things as a challenge also is the integration of HIV and the other RMNCH services, that we have people who are specialized in HIV, and then when they are on ANC, or when somebody is on, of course ANC is working, but when someone is on OPD, they cannot attend someone who is HIV positive, they cannot prompt. So eventually we are missing these children. And again, this comes with the package that we have people who are working on HIV and they are not to do with HIV. So then we are missing that. And then we are also advocating for primary health care coverage and ensuring that everyone is reached. And of course, we are also appreciating the government with the effort to roll out the universal health insurance coverage. And I think some of this will be addressed there, where we will be able to improve the quality of services, especially for some of these facilities which are not reached with some of these programs which are well funded. We also understand that stigma is also affecting the identification and also adherence to treatment. Because we understand some of these kids who are HIV positive are not disclosed by their parents when they go to school, when they go to boarding schools, and we have a challenge in terms of how they can continue treatment. So that's become an issue, again, from the parents and also to the kids. Currently, we are testing and treating everyone who is living with HIV, and also we are linking them to care and other support. And we believe that this will also decrease the new infection rate and also opportunity to get those who are missed when they are coming to the early childhood clinics. And also, we have to increase the ANC coverage and also facility delivery. Because when we see low facility deliveries, when we see ANC coverage low, then it's less likely we cannot also test these kids and their mothers. Then I said earlier about the opportunity to do the testing for mothers twice, especially after delivery, because normally we do very well when they come for ANC. And then we need to think about what can we do for the kids who are no longer coming for child care clinics. We have some solutions like PrEP, pre-exposure prophylaxis, and this is actually targeting young women, adolescent girls and young women, but also we are looking forward to see how this can also benefit pregnant mothers and the breastfeeding mothers who are at risky group. Currently, we have seen increased use of self-care services, including testing, HIV testing, home testing. So this can also be applied to mothers, their partners, and children. Of course, children cannot test themselves, but it can be through their parents. We also have another approach that is actually rolled out by partners, especially on participation of the communities, where we are looking at the community-led monitoring of HIV services, and of course, this should go beyond, where we should also question about the quality of care, and this should come from the community side, not from the politicians. And this can be done very well when community members understand what they should expect when they go to the health facilities. We'll be talking about the community-based HIV services this morning by my colleagues who will be coming after me. And then we have actually this recently, like 3 weeks ago, the new EMTCT operational plan that includes the triple elimination agenda for HIV, syphilis, and hepatitis B is rolled out at the moment, and we are hoping that most of you will be aware, and you have to find out from the Ministry of Health website, so to know what is it on it and what you can do at your capacities. We also have some activities that we're doing to support the government, including the Ministry of Health, Ministry of Education, and the Prime Minister's Office. Is it Prime Minister's Office? TAMISEMI, where we have to work together to find solutions on how we can improve the school health program comprehensively, not only HIV, so that children can be covered well. And I've talked about resource mobilization and partnership, and my colleague George will be talking about the Global Alliance to Ending AIDS for Children and Pediatrics and Adolescents in the country, and we are joining other countries. Asanteni sana kwa kusikiliza. So before I leave, I would like to introduce my colleague, Scholastica William. She works with the NACOFA, the National Council for People Living with HIV. Scholastica William, maybe I can read through quickly. She's a seasoned development practitioner with over 20 years of experience, and she has worked in the region, not Zanzibar, Southern and Eastern Africa. She has served several countries, including Rwanda, Mozambique, Ivory Coast, and others. She has worked in areas of OVC, policy development, HIV, adolescent programming, and I've seen adolescent girls and young women for HIV prevention. I think this is enough, right? Yeah, karibu sana, so that we cannot take more time for your presentation. Karibu sana.
Asante, John George. Good afternoon, everyone. As he gets me ready, please allow me a moment to be wowed at being in the same room as so many pediatricians. On behalf of all parents out there who you've helped in critical moments, in panic, thank you. We appreciate you very much. I think as soon as you become a parent, you realize a pediatrician is the cornerstone of your life going forward. So thank you. As John George has said, Scholastica Williams, I come from the National Council of People Living with HIV in mainland Tanzania. In Zanzibar, we are represented by a sister company called ZANZIBAR Plus. Sijui kama wako ZANZIBAR Plus leo? Asante. Sasa, the National Council of People Living with HIV, before I get into my presentation, we are, contrary to popular belief, we are a development organization of people living with HIV. We are not an HIV organization. So we deal with everything under the sun that has to do with making life better for a person living with HIV. So we deal with everything. We deal with pediatric AIDS, we deal with GBV, we deal with nutrition and everything else under the sun. We are in 184 councils in Tanzania, mainland, and we work directly with government departments through the halmashauris in the councils. We have two roles. We work to improve, like I said, the quality of life of a person living with HIV, and we implement projects and programs, and we work through meaningful engagement of people living with HIV, and therefore our programs are primarily implemented by people living with HIV themselves. Nothing for us without us. And the second role of NACOFA is advocacy. We deal with advocacy for any issues that impact a person living with HIV and the infection of HIV in Tanzania. So this includes women issues, gender-based violence, violence against children, among other things. So UNICEF, among other development partners, is one of our strategic partners. By that means, not only do they, from time to time, fund the things that we do, but we strategically sit at the table and see what are the real issues in the country right now, and then we work together to find resources and skills to work to implement the project. So although we, as NACOFA, implemented this project, we do it hand in hand with UNICEF. This is one of the projects that we have implemented with UNICEF. We have others that are focusing on youth that we are currently running, and we have others that we're doing UNAIDS. So don't feel bad, George. This one is called Family Center Approach, and it's an approach that we implemented over a period of 4 months. It's a pilot project that we implemented from October 2021 until March 2022. Although, based on the functionality and the real need of this project, the activities, though unfunded, of this project are still ongoing today. This project was built to complement existing programs that are supporting children living with HIV and their caregivers, that includes their parents, to support the identification, enrollment, and retention of children living with HIV. It's a community-centered that uses people living with HIV to implement the activities and support in the given wards that we selected. It was a collaborative effort between NACOFA, people living with HIV themselves, who are NACOFA, the government, UNICEF, and other relevant entities on the ground. And Family Centers approach strengthens both the caregiver and the community platforms to implement and support, to implement HIV programming and to support children living with HIV. So the overarching goal of this project was to identify and link children living with HIV to services. In many cases, those were children that were not on treatment, but in considerable number of cases, it was also some children who had been on care before, and for one reason or another, they had dropped out. The objectives, as you can see, was to improve. The main objective always is to improve the life of a person living with HIV. I know we understand that the international goals are 95, 95, 95, but for NACOFA, those goals are actually 100, 100, 100. If you would think of it in terms of a parent, you don't want to reach 95 of your children. You want all of them to know their status, all of them to be on treatment, all of them to stay alive, and all of them to have a good quality of life. So for NACOFA, that's always our driving force. We went out to support caregivers and parents of children living with HIV with information, skills, and skills and information, with information, skills, and support, psychosocial support to enable them to enroll children into treatment, but also to retain them on treatment. In the process, like I've already mentioned, we strengthened communities' ability to support children living with HIV through congas. And in NACOFA context, we work through a conga, which is at a ward level. It's a structure, our lowest structure of people living with HIV in halmashauris. Our expected results: to create awareness of HIV as it impacts children, to identify the children, to provide psychosocial support for parents who are struggling with a child living with HIV, to engage the community and have the community discuss and support each other. So in the end, what it was although we started working with the women and the parents living with HIV, the whole community then rallied in to identify children living with HIV and bring them to our attention, and therefore enabling us to bring them to treatment. We selected the priority districts both in Bear and Kongwa, in Bear and Rungwe, with a higher proportion of HIV-exposed children, a higher proportion of undiagnosed children, a higher proportion of recorded children living with HIV who dropped out of ART, and low early infant diagnosis and pediatric HIV coverage. It was an involved process involving all stakeholders. I'm not going to read it all. We start with stakeholder involvement. If we go to a place, then we would speak to the relevant government authorities who are overseeing the area. We identify what we call treatment advocates, or in Kiswahili for NACOFA we call them wakiritiba, meaning you have the infection, you've had AIDS for the most part, you've suffered through the process. It's not required, but for the most part it's the case. And then you've gotten yourself into treatment. So you can now understand your life before, during, and after. Therefore, you are in the best position to talk to the next person about the value and the benefit of treatment. Once we identify these through the NACOFA structures of Conga on the ground, we introduce these ones to Al-Mashauri. We work with the Chak and Dak, which are the district and Hamashauri authorities that are tasked with the responsibility to oversee the government implementation of HIV programming on the ground. Through them, depending on who we are targeting, we may also involve social workers and youth development officers. We then create ownership of this project on the ground, and we work together as a team to implement the project. Then we do trainings. We do it of the child care service providers or childminders themselves, parents and caregivers. And then we have separate sessions with healthcare providers. What you need to look out for, what how to support a person. I think that by now, today, we all are aware that you never know, you think you know a lot about something until someone closer to you is impacted. So we train the healthcare workers to understand themselves and their biases and what it is that could contribute to hindrance of people accessing service. I'm going to skip that because I'm told I'm running out of time. Why family-centered approach? Because it's the family that's the primary unit that supports anyone's survival and well-being. What were our achievements? Through this, we identified enrollment about 116 new children living with HIV aged between 0 and 14 within 4 months. We identified a lot more, and some of them could not access services because of one reason or another. You should see it. We trained 97 caregivers of children living with HIV, and we mobilized children to join care and treatment centers. We identified and referred 16 unresolved violence against children cases and trained 48 caregivers on prevention of sexual exploitation and abuse of children. We supported 17 adolescent girls and young women caregivers with economic and strengthening and livelihood training, and we even empowered them with some money to start their own businesses to reduce vulnerability. We created and strengthened 16 CTC clubs. We trained TAs, supported 57 children living with HIV caregivers, which were 50.4% to take COVID-19 vaccination. This was at the time when COVID was really high, and we distributed ISC materials related to that. In terms of challenges, I think these are some of the usual ones people face. Insufficient coverage of community-based HIV testing services in most places, whether it's the rain, flooding, among other things, whether it's insufficient community healthcare workers who can reach them. There was low uptake of HIV services among children, as it's been alluded to. Some of this is through own stigma. I think there was also something that we discovered, which was taken for granted, that when a parent dies, the system tends to look for the parent. If you don't find the parent, you miss the child. But if I become a guardian of a child, the system has a tendency to miss the fact that I have a child living with HIV under my roof because I'm not the parent. You ask me if I have a child who is HIV positive, and I tell you no. But we forget the ones that I might not have been a parent to, but I'm a guardian. Recommendations that we have for the future: scale up and sustain mobile clinic services, because the biggest challenge was, however many children we found, we couldn't test them as NACOFA because we do not do the testing and there are insufficient facilities for testing. We recommend very strongly the integration of family-centered approaches into HIV and AIDS programming, because, like I said, the family is the center of support for children. We will very strongly recommend increased male involvement in development programming, and especially HIV programming, because man is, in the African context, the decision maker, and we found if he self-stigmatizes, then he's not going to allow his children or his wife to seek for services. We strongly recommend integration of adolescent girls and young women caregivers economic strengthening program to reduce their vulnerability. That's the biggest issue for them. I think I would like to stop here for now. Thank you so much. Who's in?
Thank you so much for the enlightening presentation. I'd like to present our next speaker, who is Dr. Lilian B. Komba. Dr. Lilian B. Komba is working at Baylor, Tanzania as a pediatrician, and she's also the Southern Highland Zonal Program Manager. She is also experienced and very passionate about pediatric HIV and AIDS. childhood TB, malnutrition, and HIV-related malignancies. Karibu sana, Dr. Lilian.
Good afternoon. Yeah, thank you. And I come from VERDE, Tanzania. VERDE, Tanzania is a local non-government organization which provides care and treatment to children and adolescents infected and affected with HIV in the southern highland zone and the lake zone of Tanzania. What we do is provide direct care, CTC services, at the 2 centers of excellence located at the Bugando Medical Center and as well as the Mbeya Zonal Referral Hospital. Apart from that, we do provide technical support to healthcare providers in about 187 healthy facilities, high volume, in 15 regions in the southern and lake zone of Tanzania. Apart from that, we also do research, pediatric HIV-related research, and actually we scale up all the best practices from the centers of excellence towards we support the Ministry of Health into that. We have been having 5 years partnership with UNICEF in different programs, including HIV/AIDS and adolescent psychosocial support in children living with HIV in Songwe, Mbeya, and Njombe regions, as well as we have implemented integrated management of acute malnutrition program in Songwe and Mbeya region. Thank you, and let me go to the presentation. So, in the past 3 years, in collaboration with UNICEF, we have been implementing a community, facility-led community ART program in 2 regions of Mbeya and Njombe regions. And actually, this is a partnership between VERDE Tanzania and UNICEF to support the government on facilitating access, essential HIV prevention and treatment support services at the community among adolescents living with HIV. So why this? We have discovered that adolescents and people living in HIV move longer distances in accessing healthy services, and due to those distances, they incur costs and they spend a lot of time at the facilities at times. And due to the rising need of rising cases of mental health, so we think they do need mental health and psychosocial services to be provided to them to help them cope with the situation. So the project aimed to strengthen community-based strategies for adolescents living with HIV in semi-rural areas in different contexts and document the lessons learned to inform the public health authorities at the sub-national and national levels on the implication for further strategic guidance. So to describe the project, this was a facility-led community ART platform for adolescents living with HIV by adolescent peer leaders. So adolescent peer leaders are actually adolescents aged 14 to, the peer leaders actually, they were adolescents living with HIV, age 14 to 24, that is the youth, who were living with HIV and coping well in terms of good adherence and suppression actually. So these were acting as leaders to other adolescents. So they established teen cell leadership networks. These are just like the teen cell leader networks in our communities, where each child had children behind him who lived in the same communities, who he looked upon and supervised them on the ARTs. So this project has been there since 2019 to July 2022, and the overall goal was to improve, scale up, and use of proven HIV prevention, treatment, care, and support interventions for children, adolescents, pregnant, and lactating mothers. So specific objectives were to promote regular HIV care and treatment services, especially during the time of COVID outbreak. I think this is the period where COVID was also an issue. So increased capacity of the local government authorities in supervising safe COVID-19 protocols for each HIV service delivery to children, adolescents, and pregnant and breastfeeding women. To improve continuity in treatment in targeted groups, in the care plan for improved HIV care and treatment outcomes, and provide minimum package of essential care to facility and community health care providers, which helped them to protect them from the COVID issue while providing HIV services. So the beneficiaries were about 3,000, more than 3,000 adults living with HIV, more than 1,000 pregnant and lactating mothers. Children of these mothers were about 800, and youth living with HIV about 2,000. And it was implemented in 2 regions of Mbeya and Njombe regions. Mbeya we were linked with facilities, healthy facilities. So we had about 16 healthy facilities in Mbeya, while in Njombe we had about 22 healthy facilities which benefited from these programs. So apart from that, we are working in collaboration with government officials, the district social workers, the regional social worker, CHACs, the healthcare providers, and the teen cell leaders. The implementation sites were the Chimbo. Actually, the Chimbo here is a physical space in the community where adolescents living with HIV met on monthly basis for ART refill, psychosocial support, sexual reproductive health and rights, education, and income generation activities. So these areas were chosen collaboratively with the local authorities and influential people in that locality, and they were really considered confidentiality and privacy of these kids. So what the package we gave this to implement this activity was to orient the RSHMT members on their program and actually on their supervisory roles, and this helped us to mobilize the ownership of these members at their localities and the program. We also trained about 220 adolescent peer leaders who oversaw all these kids at their chimbos, and about 80 healthcare providers who came from the healthy facilities we were supporting, who were acting as supervisors to the adolescent peer leaders. We managed to establish about 87 chimbos, these networks of adolescents living with HIV who were stable on ART, and supported community meetings for these kids at the Chimbo areas and the Jitambue sessions. And we managed also all children who were to join the chimbos were children who were termed as stable. We know stable and unstable. So these kids, for them to go on the community ART, they needed to have that criteria of being stable on ART, that is full suppression on ART, on HIV suppression. And so what we are also emphasizing here was promotion of being from stable, unstable, to go to the stable. We also conducted these collaborative quarterly mentorship meetings with RSHMT members. So the expected outputs was to increase capacity in supervising safe COVID-19 protocols, as well as a total of 3,300 adolescents to be knowledgeable with COVID prevention skills and retain into HIV care and treatment plans, and a total of 1,000 pregnant and breastfeeding women and their children to also be retained in treatment during the COVID-19 pandemic, and about 2,000 youth living with HIV were also knowledgeable with COVID-19 and SRH information, GBV, positive BCC messages, and life skills. And apart from that, we expected to draw some best practices on community-based HIV treatment and support services that will be documented, costed, and shared in different forums, including this. So these were the achievements. As you can see, more than 9,700 adolescents, children, about 3,000, and pregnant and breastfeeding women benefited from this program for the past 3 years. And we had about 210 adolescent peer leaders who were capacitated to lead these Chimbo sessions, and 87 platforms for Chimbo for different areas, as well as we managed to upgrade about 1,000 children who were unstable and promote them to be stable through different adherence sessions. So there were some peer-to-peer psychosocial support through SMS messages, so at least they could send these positive messages and educate their fellows on COVID, on HIV, and things of such. So the program unit cost for a person was about 296,375 Tanzania shillings per person to run this program in the past 3 years. And the most cost came from the trainings, which was the more costly expenses, which was incurred in programming. But leading a Chimbo session was the least costed activity. And actually what they needed was just transport for the leaders and communication allowances. And the healthcare providers to travel from the healthy facilities and bring the refill medication to the Chimbo area when it reached the refill time. So what we used to do in this program is the facility healthcare providers would come to the Chimbo areas for the refill clinician visits. I think in RT people can understand that. During the RT refill session, the clinician will just come to the Chimbo and provide the medication and solve other issues, while on the consecutive visit, the adolescent peer leaders will just lead the sessions by providing education to their fellows on GBV, on adherence to medication, psychosocial support, COVID, and everything. So the challenges which we faced was mostly the confidentiality and privacy of the Chimbos, and dropouts affected by teen cell leader support due to migration, and sometimes limited to work in school or settings. So the opportunities was to support from the RCHMT, collaboration with network of young people living with HIV, like the NACOFA, scaling up adolescent mother mentors who provided psychosocial support and things like that. So key findings is benefited from existing partnership and the government structure as we involve them in planning and in implementation, partnership with community organizations, which we found that when we mapped the organization which were working in these regions, and we managed also to have those 87 Chimbos with privacy, although we had some Chimbos which dropped down, and established grassroots community-based adolescent peer-led to conduct awareness and demand creation of ART services. We also managed to retain ART clients in care and treatment. So lessons learned is to avoid overlapping partners. It is important to conduct mapping of all partners. Supporting the Chimbo technically and financially is instrumental in sustainability of the project intervention. The sustainability of the Chimbo can also be best achieved when there is strong collaboration between different stakeholders. The Chimbo attracts many adolescents free access to reproductive health services, ART refill, and healthy checkups. We also integrated review meetings, helped to leverage the available resources, reach more adolescents living with HIV, and helped enhance program ownership. So sustainability plan was to establish income generating activities, because most people when come for Chimbo, they look for opportunities. So also to empower healthcare providers with skills, to manage teen cell leaders, and as well as to adopt the community ART model into the council health management plans. So the documented best practices include, of course, what we brought we did some reviews and focused group discussion, key informant interviews and desk reviews, and these were the best practices which are documented, that the partnership between the implementing partners, the BAILA, the UNICEF, and the government officials and other NGOs like NACOFA, COCODA, to strategize, and use of existing government structures. Like we see, we involved the social welfare to deal with GBV issues and issues of stigma, integration of multi-month scripting, so it was the government priority by that time, so this program helps to scale up such initiative. The involvement of adolescent peer leaders, of course, as we say, there is nothing without nothing for us without us. So the peers were able to be, were included. Integration of government-led HIV and COVID plans, support development of guidelines, protocols, and operation procedures, addressing stigma with support from district social affairs, support peer adolescent leaders and healthcare workers to retain clients into the services, integration of income-generating activities in the Chimbo site, and utilizing an adolescent mother-mentor model. Designated physical space is welcoming and safe, the Chimbo. And the mode of differentiated HIV service model aligned with government policies and priorities, as well as maintaining ART services during the COVID pandemic. Asanteni.
Thank you, Dr. Lillian, for showing us what you're doing with Baylor in the Southern Highlands. Our next presenter is Dr. George Loy, and he's a medical doctor. He's also a palliative medicine physician and a public health expert. He's worked extensively in public health programs with a focus on HIV and AIDS and TB. Currently, he works with UNAIDS, and he's actually the program advisor and Zanzibar liaison officer. Karibu sana, Dr. George Loy.
Good afternoon, everyone. I think after we have heard from our colleagues, starting from John, Lillian, and Scholastica, mine is just really to raise some awareness on some new development. So I'm not going to repeat through a number of issues that we had planned because of in the interest of time. So we have seen that progress has been made in the HIV response overall and for children. But obviously we have seen the gaps in the children HIV response. And so I'm going to just take a few minutes to really bring to your attention as an important stakeholder in the HIV response, particularly for children. And we have seen the numbers that children are lagging behind. So this is a rare opportunity, I should say, for us, that we are having this big gathering here, and we have a new baby in town that is calling attention for the world, including our country, to pay more attention to pediatric HIV. So recently, there's been a new sort of multi-sectoral guidance that is trying to bring the world together to really do things differently when it comes to HIV AIDS in children. So we have the new, what's so-called the Global Alliance to End AIDS in Children by 2030. So for us here as Tanzanians, we take this as an opportunity. So I'm just calling you to be aware of this new tool and to engage at this early stage. You are an important partner, you are an important part of this mechanism for the globe as well as for this country. So, as I have said and we have seen from the number that colleagues have shared, this global alliance is calling for us to do things slightly different to make a difference in the progress that we have already seen and accelerate for more impactful results. So one most important message that this alliance is calling is for taking bold actions, and actions that are focused on ending HIV and AIDS in children. It is calling for many sectors to come together. It's not an isolated, it's not for an isolated sector, the health sector. It calls for everyone from many sectors. As you have seen, many of the challenges that are hindering progress towards achieving targets have got many faces. Sometimes, or actually most of the time, it's beyond the health sector. So it's calling for many sectors to come and join hands. Importantly, it's also calling for having country teams that will look at the challenges at the context of a specific country, and therefore having create solutions that are context specific based on the nature of the epidemic in that country. It's also calling for mobilization at multiple layers, globally, regionally, and at a country level. Mobilization for leadership, because as you might have gone and seen through the previous initiatives, leadership has been seen as a key for any successful eliminating AIDS in children. Also, mobilization for funds. We know and we cannot have one word to say about how important funding is. Also, importantly, to mention here is that we have seen shortfalls in the pediatric AIDS in terms of the quality of service. It's not just about the numbers, but also the quality. This is very important. Over the last 3 years, we all know what COVID-19 has, how it has impacted negatively on many aspects of our life, including the HIV response and specifically pediatric HIV response. So these are issues, these are facts that we have faced, and therefore we somehow need to look into how we do and act different to make a difference in terms of results. Therefore, as you all aware, there were 2 important sort of developments last year when it comes to the HIV response. We know there's a new UN political declaration on HIV, the 2021. We know there's a new global AIDS strategy that will run to 2026. These 2 important high-level advocacy tools exist, and therefore the world has come together, read from what these key documents are putting out there and really specify issues that are specific for children, given that we know children are lagging behind. And therefore, this document gives us an opportunity as a country to think and see how do we want to make a difference in the HIV response, particularly for children, and therefore is an opportunity for us. Let me, I think I've gone to that extent. I just want to raise that currently there are some new developments in terms of how the alliance is going to be operationalized globally and to the country level. And this is just a suggestion that is shared, that we know that from many years ago, over the last 40 years, there have been policies, normative guidelines, and strategies, global, regional, and country, on HIV/AIDS that tell us what and how to actually prioritize our intervention. But at a large, actions have not been bold enough. So this alliance is now calling for bold actions towards the plans that we have at hand. And particularly, attention needs to be given to coordination, because coordination has been seen as important if we want to achieve impact that is sustainable and will lead to us ending AIDS in children. So I just want to remind you that there were 2 important documents that existed. The global plan that was implemented between 2011 to 2015, and the 3 free guidelines that looked at children, mothers, and adolescents. I don't want to repeat this. And these documents have helped countries, including our country, to move from where it was to where we are. Now, a lot have been learned from these guidances, including, as you can see, at the country level. And therefore, the new alliance now have learned this, added what we have so far, and come with measures that we think, if well coordinated, implemented, will make a difference in the HIV response, particularly towards ending AIDS in children. So the focus, the vision is really about ending AIDS, and there's a call for action-oriented programming, not just having guidances. And the focus, as you can see, it's really focusing on a number of suggested broad activities that we need to look and reflect at a country level, because these are global, regional sort of suggestions, but each country needs to look and reflect on the exact situation in the country and come up with its own sort of strategic plan. And therefore, as a country, we need to look at that sort of suggested global sort of design for the coordination and provision of support to countries, whereby in whatever we plan as a country, we must make sure that mothers, children, and adolescents are at the center of this program. And as you can see, as suggested, it's going to be a global leadership forum that is going to look into mobilization, political mobilization, resources, and advocacy. This is going to be a global leadership forum. Then there are going to be global technical working groups that are going to look into specific themes around ending AIDS in children and adolescents. And then we're going to have regional hubs. Our country, Tanzania, has got a set of 10 countries, as you can see there. We're going to operate as one regional block, and we're going to have a secretariat that is going to be, as it is now, is going to be providing technical support and technical assistance for implementation and reporting, and it's going to be particularly led by UNAIDS, WHO, or UNICEF. More importantly, that I'm calling for us now, as a country, we have country teams, and the process has started, and I'm calling for Paediatric Association Tanzania to take part at this stage in the making of the teams, because it's really important, as I said, nothing for us without us. So as key partners and stakeholders in the HIV response of children, you need to get engaged from this early. And I think from here we can, I can provide updates in terms of what to do next for the Paediatric Association of Tanzania to be a part and parcel of this process. And you can see the Alliance is calling for this movement to go for long period of time. So it's divided in 3 phases from this year to 2030. And we are now in phase 1. We are actually doing, bringing people together, the partners. So it's a call for us to be part of this as we continue working together. So let's think as Tanzania, what do we need to do differently? Despite having significant progress so far, what do we need to do differently to make different results which are more impactful to our communities? So as we look into the regional launch of this alliance, the global launching occurred in the past International AIDS Conference. So the regional launching is supposed to happen sometimes in November, and there are some suggestions that it might be in Tanzania. So let's get prepared. Let's think as a country, what do we want to do different to make a difference in ending HIV/AIDS among children? Thank you so much.
Thank you so much, presenters, for the enlightening presentation on pediatric HIV, and I think we learned a lot from the global numbers, regional numbers to the country numbers, and pediatricians in here, we are the advocates for this population that we are talking about, and I will call all of you to not just to look at the numbers, but just to know that all those numbers are children that we save. So just look and say, like if you can compare the dates with AMSI. Do we remember AMSI? Yes. Or do we remember what? MV, MV Bukoba. So those are the things that we can really reflect into our daily activities and see how many of the kids are dying, and we are there to save them. And fortunately, at this era, we have ARVs that can save life. If we get them early, we start them on treatment early, and we make sure that they remain on treatment, they are virally suppressed. And as we embark into the U is equal to U, we are calling upon for everyone really to contribute in any way to make sure that everyone is taking care of the population that we are saving. So I'm going to have, we still have 15 minutes to ask questions, comments. So we'll take 5 questions, really burning questions or comments or additions to the presenters. So please, when you ask your question, you direct specifically to who you want to respond to that. So karibuni kwa maswali. Prof. Karim, nimeona mkono. Kinyosha mkono, please. Nyosha sana nikuone. Professor Karim, nimekuona, asante. Anybody else? Karibu, kule nyuma naona kuna mkono.
Thank you very much.
Abe? Yes, karibu.
Okay, thank you very much for this. I missed a little bit of it because I had about and I didn't want to start so early because of the AC. So don't be afraid, I won't forget. So my question or my comment about implementation HIV in children. We have research happening in Tanzania, and I happen to review a lot of literature on it because I am working on some of the research. And there are so many papers published, very important on like task safety, patient satisfaction, satisfaction of the nurses on field issues, exit interviews of the mothers about field disease, and PITC issues. And in the research which I have done of trial of vitamin in HIV positive pregnant women who are on B+, 2,380 mother baby issues. It is a placebo-controlled trial of vitamin B. Did not find any benefit of vitamin B as compared to the placebo. But what we found as side effect this book was that the appearance and the compliance of mothers who have these children were infected. Out of the 2,380, 340 children were infected. Yet they had gone through a PMVC program. So what went wrong? You can say it the other way. Out of 2,300, 300 got infected. Says that 2,000 did not get infected. But either way, it is a very high number. That's also in a research setting. So there is something wrong in between, whether it is clinical counseling, mixed feeding, or what. So something more is needed to be done.
Yeah.
And then there are, within the team at the PMVC center, the healthcare worker says, you started this medicine so early, I don't know if your child's brain will be alright. Because you started when even the brain is not developed. So they are fearing to start. There are maneno. I'm saying this out of experience and scientific information, and I have a paper published on vitamin B and pregnant women. So for the children, we are now doing a neurodevelopment assessment. Now they are 3 years old. So we are doing various tools using the WHO guidelines and VERDE and IDELA and other tools to see how is their school readiness, including WIPC and other tools, to see what is their developmental capability compared to. So this will mitigate if, or we find if there is any problem. So we need to see more in those best practices, either universities there. What can we do to improve the compliance? Now when they are 3 years old, those 300 children who are positive, half of them are no more. Because there was no compliance. So we need to look into this a bit more at a micro level, I think. Thank you.
Yes, actually we tolerated you very much because we know it's your teacher, our teacher. So for others, please just be specific to the question and ask the question. We have 10 minutes for this session remained. At the back, there is.
Thank you very much for these really nice talks. I have a question to the young adults, like 5 to 15 years, and you said it's really important to address them. Actually, have any of you experienced at what time you would disclose HIV to these children? I think that's a really difficult point. The kids doesn't know that it's HIV positive. How does it feel? Should these children? Yeah, that's my question.
Yeah.
Thank you.
Yes, a third question from that lady.
Thank you very much for announcing an excellent presentation. My question goes to Dr. Lilian. I want to know about the sustainability of the programs like yours, because there have been so many programs looking at community delivery, ART programs, but then at the end of the program implementation period, things usually go back to normal. So I want to know, for example, after 4 years of project, what is the situation now at the chambers?
Yeah. Any other question? Yes, from Tumuga.
Thank you so much for a nice talk. But just to, from your presentation, you see that the children actually don't have sufficient biosuppression. So are there any efforts to look at what could be the causes of insufficient biosuppression? Maybe it could be due to low immunity, maybe it could be to they using, we just transport from the adults, or maybe it could be we have late initiation of ARTs. What would be the reason? Thank you.
Thank you.
Okay, so we have 4 questions already. Anybody else with the last one? Okay. Edward, is that you? Okay.
So I have one comment and one question to Dr. Lilian. So my first comment goes to the first presenter. One of the observations, adding from Professor Manje's comment on PMTCP, it seems the PMTC coverage is really high. You see in 2020 it was about 90%, but see the early infant diagnosis for HIV is still low at 55%, which shows maybe the quality of the PMTCT. Sorry. And again, the other comment goes to Dr. Lilian. We see the HIV virus suppression is still very low, and the high number of the children living with HIV is adolescents, which have higher, more issues death. And this practice that she was presenting today is one of the best practices that we can adopt. So my question is, do you plan on scaling up, or what's the plan with the scaling up of this program to other regions, so that I think this will improve the, at least on one part of virus suppression, turning to adherence? Thank you.
Yeah, so we have 5 questions, and I'm going to call upon the panelists to respond to the questions. I think, George, you had one, and Jojo, you have one? Yes, please.
Thank you for good questions, and I appreciate the attention that you can even remember numbers that I was presenting. Normally, it's not easy. Actually, you are truly pediatricians. Yeah, so thank you. Just to let you know that, of course, some of the questions can be responded to any one of you, because some of you are pediatricians who are working on the HIV clinics. But maybe I can ask a question. Ile dawa mnaita lopinavir. Nani anafanya kazi kwa pediatric clinic, nini HIV clinic ya watoto? Anyone, if you can show up your hand? Oh, thank you. So if I may ask a question, nani anajua ladha hii lopinavir, for example? So, oh, I'm very glad to see this. So ile dawa ni chungu sana. So I can imagine for children who are not able to drink porridge, which has sugar and milk on it, how hard it can be to use that drug daily. So I think that's something that I think, is it empathy or sympathy? Empathy, wearing someone's shoes, so to understand what it takes. I think some of you have had malaria, and some of you might have not completed the dose, even for 3 days. So you can imagine how hard it can be for parents and caregivers to continue with the treatment and actually adherence. So there are many factors and issues, and we have been working with the Ministry of Health to do the kind of supported information and supporting mothers to understand and what to do, how to care and help their children to continue the treatment. But it's very challenging. When it comes to viral load suppression, I think this is also related to ability for the kids to also chew, and actually the combination preparation of the drugs for the mothers to give the kids is not really easy, and actually that also affects how the treatment outcome and the health outcomes that they can express after the treatment. But again, we are seeing some logistical issues. I understand that some of you understand that we have about 200 facilities or sites that can provide point of care services. Sawa? So it's not easy to do the testing for these children. Kwa hiyo wanachukua ile nini sample, and then it has to be taken as cascade, and then it can be delayed. Sometimes the turnaround time is very long, and then mothers may not come back. So eventually we lose these clients, and then of course they may die because they are not on treatment. They can go into other complications. And then, so we have to work together, and this has to be with the lab people, colleagues from NACP, and the PMTCT colleagues to support all these efforts. But then for those who are 5 years to 14, now it's a challenge that the disclosure will be happening at 12 years, right? Around 12 years. Of course, it is phased disclosure. And now, by 12 years, they have to be well informed. But we have seen some kids who do not know their status, and now they are being told, that they are taking medication, and then when you ask them, they'll tell you that they don't know why they are taking medication. Of course, there's an issue of quality of service, but also the stigma also, it's affecting how the parent can disclose, and the support also, make sure that the schools, they can also be supportive. But also we have seen stigmatization at the schools. Mwite yule mtoto mwenye virusi aje kunywa dawa. So actually it is very, very, very challenging when some of these teachers or matrons can really use those kind of language. Of course it is fine because we can say the same for, please call the COVID patient. But I think it's disrespectful when you do that, when you identify people by their diseases, and of course for the kids, when it is to do with the psychosocial and mental health, now it's not easy for them to, and of course they don't even know why they're HIV positive. Unaelewa? Yeah, sorry, I think that time is up.
Yes, so the other from Bela. George, get ready.
Yeah, so if I start with a comment from Dr. Karim, I think. So why most people who are on PMTCT are the ones who will turn up positive with kids. So I have a few things, maybe literacy among the healthcare providers in providing disclosure and their insertions, as well as the literacy among the healthcare providers on the overall HIV concept. The other thing can be disclosure issues and between the partners. If the partner is not disclosed, that means it will be very difficult for the mother to provide medication to the kid and herself to take her medications. Another one can be showing up too late at the ANC at first visit. It has shown that the ones who are newly diagnosed, they have high viremia, and literally they will definitely infect the kid, as well as young ladies who get pregnant when they're still young. Also, most of them will turn up to be positive and will show up very late at the ANC. The other thing is maternal retesting rates are very low, so missing up opportunities to get the infected children. So about disclosure, the disclosure, as Mr. Jones said, disclosure is normally done, partial disclosure at before school, around 6 years to 7 years, which is partial disclosure. Then full disclosure is about at 12 years. But as well, we normally do disclosure prior, maybe about 10 years, if a child, according to how the maturity of the child as well. So we prefer the disclosure as well. So Dr. Gertrude also asked about the sustainability of the program. Yeah, of course, on the sustainability, we try to buy in the ideas of the local people, the local government, as well as the RCHMT, to include community RT through their plans in the regions and councils. So apart from that, the cost which was very much encountered was the trainings and things like that. So we are still calling for people who can support such things, or the trained facilities to scale up to other facilities in their own councils, using their own funds from the within. If they have a will, I think that would be better. As long as the chamber, we linked them with income generating opportunities, like youth funds in the councils to help them with the nauli to the chimbo areas and things like that, and to communication allowance. And as for now, these children are all under the NACOFA, as they are still overseeing them, and if the program it's still existing, actually, yeah. So from Edward Ngalia, HIV, if we are planning to scale up, of course, yes, given the opportunities, and in our supported facilities, we have different models on the DSDMs, which we support, like the fast track, maybe the group refills, and community RT as being one of them. Thank you.
Thank you, Lily. Is there any question that was not responded to? There was one to George. Was responded? About? There were no questions to George, right? I can't recall.
Yeah. Yeah. Thank you. I think maybe I just want to touch on one my teacher, Professor Karim, have intruded into. And he has used the zinc and vitamin D as an example. But that one really tells us a lot in terms of how do we, from the practical point of view, how do we listen to science? How do we take the evidence that has been generated and put into practice? How does it inform our guidelines and our practices? That's a very important thing that really we need to insist in. And that's why the new Global Alliance is calling for, is taking action based on the evidence that we are getting from the field. That's very important. And again, to mention on one of the questions from one of the colleagues in terms of the fact that at one point PMT coverage was high, but early infant diagnosis was low. So this again tells us as to to reflect on our practices. How are we taking, how are we integrating our services? Early infant diagnosis and PMC coverage. These are the issues that go hand by hand. So they need to sort of complement each other and stop being run as sort of separate entities, which will really sort of jeopardize the quality and the completeness of the program. Thank you so much.
Yeah, so we have come to the end of this session. I would like to thank the presenters and those who asked questions and the listeners as well. And I think right now we are going to break. But before that, naomba tuwapashie mpasho wa watoto. Who's gonna lead that mpasho? Anybody volunteering kuwapashia? Yeah? Najipashia mwenye? Okay, so we're gonna pasha like Obama Kilo. I want someone to lead us on Obama Kilo. Jackie Suba, are you in? Okay, if you're not in, then let me pasha for them. So the Obama Kilo goes is, I will say, so we should stand up. So the Obama Kilo goes like this, I will say Obama Kilo. So we start from the left, we will do like this. Yes, okay, so Obama Kilo.
Thank you, the panelists, and thank you everyone for being so attentive for today. So we are going to break for lunch for the next 45 minutes, kind of observed time. As you go out to receive your coupon for lunch, please make sure you have one, otherwise you will not be welcomed, unfortunately. So please take your coupon, and lunch is served at the restaurant just across. Looks like we might also to go for lunch. So lunch will be served just across the corridor. Please remember to take your coupon on either doors. Yeah, some of us can come on the front part. Karibuni.